parameters. And we used ASHA worker. ASHA worker, I think most of us know. They are not trained, they are only trained for the primary, but we trained on-site 4 ASHA workers to how to use ECG. And we sent those ECGs to PGI, and we found that except 4 or 5 ECGs, they said all are perfect. So as far as training part is concerned, we have to build ourselves. People are ready. People are ready to learn. We have to see how we can do it. These are the camps. This is rural business models are also there, and these are broadband connectivity of eSanjeevani on the cloud. And to conclude, I will say not only eSanjeevani is on cloud, but it is on mobile also. Any device, use it, it is there. And you can fill your parameters over there, and you can get the, you go to www.esanjeevani.com and put your password. It will be, you will get the annexures, wherever you want to put, you put your parameters, send it, choose a doctor, your doctor will reply back to you. This is available. And definitely in the next, we will be using it. Thank you very much.
Thank you indeed. Make a simple comment that we've heard about seamless information technology that supports healthcare. We've heard about seamless data, seamless connectivity, seamless measurement that's accurate, and seamless communication. So all these sort of innovations coming to the forefront. I think we have a question here.
My name is Rifat Latifi. I'm from University of Arizona in Tucson, and I work in a few telemedicine programs around the world. I want to congratulate Dr. Ganapathy for putting the last speaker last, because truly it was what the telemedicine should be and what we should all strive to do. I don't really care much if someone can look at his EKG on the iPhone, iPad, computer, or get so obsessed has to do it 7 times a day. I think he needs to see a psychiatrist, not a cardiologist, if he does that. Right? Thank you. But I really congratulate you to providing and sending access to those in the villages, those who, in order to go to take the telemedicine unit, you have to put it on patients' back or people's back or horses or donkeys or whatever. We need to do that. So congratulations. And yes, it's very cost effective. You do your own analysis. We published this in a Kosova's example and in Albania, and completely cost effectiveness. Absolutely. No question about we need to find a way how to make physicians more adaptive to this, but actually physicians like to help their patients for the most part. And I completely disagree with last night's comments about all the doctors are bad. They're actually not. We have a lot of issues, certainly, but they would not, 50% of us are not average, otherwise they would be firing us left and right. So congratulations, and it was the best thing I heard today.
Other hints to the entrepreneurs that the future holds business in the rural. As you know that many of these business has been now migrating to rural areas, and many of those things have been shown to be profitable by the company like ITC. Now this is another way where entrepreneurs may think how to take from the Gram Panchayat to the village doorstep. If you have a macro entrepreneurship, some kind of thing in your mind, so here you can, from the Gram Panchayat, you can build up to system with some kind of backpack or some kind of portable wireless health terminal and give services to the village level doorstep. I'm sure now the villages have that much of payment capacity to pay for their sugar testing. They know that diabetes is a problem. and hypertension is a problem, but they cannot comply to the doctor's advice to come to the nearest district level or city, nearest bazaar where there is a private practitioner sitting. And again, I hint to the private practitioners working in different small taluka level to build up kind of business opportunities and talk to the patients while they encounter the first diabetic in their clinic and telling them, these are the options available and this is my agent, they'll go to your doorstep, check your blood sugar. I'm sure the villager will not mind paying him 50 rupees. This kind of micro-entrepreneurship has to come up to cater the 70% of rural citizens living in our country. I again congratulate Sidak Mohali using all indigenous technology and indigenous knowledge base to deploy such kind of projects. And mind you, anything not indigenous which is going to really cost more for our ventures, which may not be profitable.
Myocardial ischemia, etc., etc. We do not have the limits of normality for huge data for continuous points. My plea to every one of you is, please, I am a technology buff, otherwise I wouldn't be here. But at the same time, do not treat a laboratory value, do not treat a graph, do not treat a sound, treat a human being and correlate what you find with clinical symptoms, even if it is a pre-symptomatic diagnosis. I am worried that because the multinational companies are pushing us so much, it's beautiful graphs, beautiful photographs to show that you can diagnose an arrhythmia before even God thought of the arrhythmia to get it to you. That is the level of technological advancement. There is data to show that unnecessary bypass surgery, stenting, this, everything has been done as a preventive measure. It is not equal to giving polio drops. I don't mind giving polio drops to prevent polio, but I, for one, certainly do not want to do a 640 slice CT scan, which for every senior citizen will show a 20% coronary artery stenosis, will show atherosclerosis. These are all normal aging processes. Please, please, please do not remember that this is a tool to achieve an end. In spite of what Vinod Khosla said yesterday, you require a human being to interpret that data. Tender loving care is what is important, not telephone link care or television link care or telemedicine link care.
What NHS did is basically they identified those patients, the doctors identified those patients who are having high blood pressure and who are having like diabetes kind of a thing. So what NHS did is they basically told those patients that, okay, you are having this kind of a symptoms, so I'm going to give you this device, you have to take this device home. And then they gave a schedule, the doctors gave the schedule saying that I want you to take these readings in these particular times and then have it sent to me. Nobody can replace a doctor, right? At any point in time, if I am sick, the first thing I would like to see is like, okay, where is my doctor and what is his number, and call him right away. But all these technologies and devices, what we are trying to do is like we are trying to bring some value add to the doctors so that like they can use it. So as NHS was using, that is one of the articles that I found in the web, and actually there is one Word document also where they said how to use the device and how you can help yourself in identifying this issue and reporting to the doctor right away. So this should be taken more as what I call it as an additional tool with the for doctors and physicians and specialists to diagnose it effectively. Thank you.
Hi, my name is Raj. Question is, there have been articles about how this wireless communications are impacting some of the small birds and some of the small organisms. There is a definitive impact on the ecological balance. So what is the responsibility that we have towards restoring the ecological balance?
Ecological impacts of some of the technologies we've been talking about.
Very good question. To answer this, first and foremost, any of these devices that is being made should conform to standards. And there are specific FDA, AMI, and BHS standards which very clearly says what is the operating range of these devices with respect to radiation. So one of the things I think the government of India is also doing is like not allowing every device to come into the market without ensuring that whether they pass the radiation levels. So there is a testing that is there in the hardware side, which we call it as EMI, EMC testing. which will ensure that the radiation levels of the devices are in the area which is not harmful for the human being and also for the other kinds of organisms. So that is the most important thing and most critical thing. So I would encourage any device manufacturer to ensure that you are complying to the standards and making sure that device is helping to save lives and not taking away lives.
Times to see the whole enterprise evolving around home care business as a potential area, whereas it's been there since 1970s in the West. The technology has started evolving around it just for the last 5 years. So that's one of the part of it. But I have a very simple question to Microsoft. As when I was studying in a medical school, there was a thing called Health Vault, and it's not there now. But with the cloud, are we going to see the Health Vault 2.0, or is there anything that's coming up? That's the question.
So I'll just take a minute to explain what Health Vault was. Health Vault is a solution from Microsoft, which essentially is a personal health record on the cloud. And the reason why this is has a fair amount of impact is that imagine the patient having control of his personal health record regardless of where he's going across geography, where he's going across, if he were to travel from go from one hospital to the other, the entire aggregation of it is happening on a personal health record. Microsoft is working on trying to see when we can get Health Vault into India. There are also the EMR standards for India is something that is coming up and is in draft stages. And we are mindful of what is going to be there in that, and then what are the customizations that would be required for Health Vault to bring it in. So that's work in progress. Thank you.
Your participation indeed. I think we're going to wrap up this session and look forward to great innovations from not only this panelist, but from all of you. Thank you very much.
Thank you, sir.
Any last session at all. We have been rather strict on time management for obvious reasons, and in the next 20-30 minutes, we are going to give an opportunity to give us bouquets, but to give us brickbats, criticize us as much as you want, with solid evidence, of course. Please tell us what you would like to do, what you don't want to be done, and what you think should be done to make healthcare information technology a reality in this country. Sorry, sir, I'm intruding on you. This is just to save time. May I now invite Arvind Shivaramakrishan. Where is Arvind? I thought I saw him somewhere here. Yeah. And Mr. Arun from Microsoft, please come and join us. The plan for the next few minutes is that we have asking discussants for each session, very experienced senior people who are going to be given exactly 300 seconds each, and they are going to tell what in their opinion was the take-home message of that particular session as given by the speakers and then supplemented by their own thoughts. After all the sessions are quickly reviewed, we will then leave it to the house and to get inputs from you. Now, before I hand over the mic, I would like to express my personal sense of, I am absolutely delighted. I have been attending conferences, neurosurgical of course, from 1975. That's a pretty long time, 38 years. I'm just not able to remember any conference where on a Saturday evening, the last session, we have almost 100 participants actively involved. I think this speaks for itself. We are not interested in quantity, we are interested in quality. And the very fact that all of you are still here is absolutely thrilling, and I think that's all that we want, a sense of participation. So yesterday we had 31 talks, today we had 25 talks. I'm not going to go over everything. The first session was called Deployment of ICT in Clinical Care. Is Dr. Anjali Mishra here? Oh, you are speaking on, okay. Dr. Saroj Mishra, may I kindly request you to come to the floor and just tell us what in your opinion was the take-home message of the clinical science. The session on clinical.
Then we have also some of the presentations showing in the cardiac care, and also some of this presentation involving in primary teleconsultations services, and some of the home care applications. So I think these couple of application scenario, it tells us that the technology has really kind of accepted by the patients, because patients are our stakeholders primarily. So patients accept that they can use this technology to remain in their primary caregivers in a home care setting, or to access some of those telehealth access point, even if not home care, but telehealth access point near their home to reach across to the primary care service provider. So that I think it is one of the take-home message that we can think of building such kind of service model. The second point that has come up from Kathmandu, Nepal, is the home care, and these are the situations where poverty is very high in most of these emerging economies. So in rural areas, this home care is one of the very good concept that one can take up. Unfortunately, the communications and network are now available in a wireless mode, whether you talk about cellular network or the upcoming Wi-Fi Max network. That is going to make this home care in the rural areas a success story. The two important things that I have learned from this session that is going to have a lot of applications. Other message that we got is some of the hospitals are building enterprise-wise network to reach across to their, in business term we call them clients, but we talk about the patients, to reach across patient, and we have some of the hospitals now taking up Apollo in a big way, and they are tying up with the technology innovators. That's a good message that I'm getting in comparison to the earlier version of this conference. Last year, we didn't have so many gadgets, innovators that is coming up. But this time I saw that, many of those companies, the Qualcomm and the Xerox, and I saw the Hyderabad-based company, the wristwatch coming up. These are very innovative products. But unless you really integrate along with the normal caregiving scenario, this is not going to become success. So I request those companies who are into production of these kind of gadgets to collaborate extensively with the hospitals, having doctors who have technology bent of mind, to integrate this person. Next year we find some of these applications and the results coming out of it. So these are the couple of messages that I got from this clinical application scenario in terms of already matured applications and also like continuity of care. And the second is the new gadgets coming in into the enterprise telemedicine service delivery.
Could you also give us a few comments on the panel discussion on...
At random, we have got up a lot of messages from different people like us who are working with the government. So in that, 2 or 3 messages I want to again repeat for you in case you have forgotten. One is the National Knowledge Network initiative that is coming up from the National Knowledge Commission. And this is really a kind of boon for our country. Not only to just talk of any government-aided projects, but you can also build up a lot of application-oriented thing and tell the government that this is possible in health scenario, whether it is a education, whether it is a skill-sharing initiative, or it is a kind of healthcare initiative that is going to come up. And please remember one thing, that NKN is going to merge with NOFN. The NOFN, though NOFN is being governed by another group, but NIC is implementing both the projects, that is NKN as well as NOFN. And there is a talk going on that they may include both this Broadband Authority India Limited under the same purview of National Knowledge Network. And this is again coming up in a broader umbrella of that is called Innovation and Infrastructure that Mr. Sam Pitroda is now leading. This is the next edition of National Knowledge Commission which Mr. Pitroda was leading. So you will find this kind of national infrastructure, e-infrastructure, has a lot of potential. You just close your eyes and think that if you get such kind of bandwidth, I always compare this bandwidth with our highways that you see here, Golden Quadrangle we have now cutting across the country actually. So you can think of applications. Most of these companies are sitting here. Please think of applications because we need you to build up applications for the government. So NKN and NOFN, one. The second thing is the standard. So again, I am putting you across this information. The national standard for electronic medical record is already being over, and 2 years of consultative process have taken place. and all the inputs that are being invited from different companies involved in the implementation of hospital information management systems were taken into account. And still, if you want to give more inputs, be in touch with the ministry. We can give you, Arvind is from here, Apollo, he's involved in a big way in this EMR. So if you are interested, please be in touch with these people who are into this EMR business. It's very important that whatever gadgets you are making it, please adhere to the standard. Okay, you can talk of FDA standard, all these things, because Government of India may not take the FDA standard or CE standard into account. Okay, those standards have made your product one of these acceptable product, but you have to adhere to the standards of the Indian, that is Ministry of Health standards. 100% I think you should be able to meet it, but at least you should know that we have to have the stamp of Ministry of Health initiative standards to be into the market. And I think in terms of business, I can only forecast you, and many of you must have been already into business, because the electronic health record is going to be mandatory for all the Indian citizens in the near future. It may be linked to one of the unique unique identification, be it Aadhaar or be it some other things. So those things has to be there in the place. And Ministry of Health is thinking in loud terms that patient need not be transported, or patient should be at own place, or patient goes and he owns his own record and tells the doctor in different city, this is my ID, please access my records. So that kind of thinking that Government of India is now thinking. So that can only possible through the companies who are into business. And I personally feel that in this particular century is for at least this decade I can talk of. For 21st century, I don't know whether I'm going to see or not, but at least this decade, I think it is health IT. Because you know more in business, but as a doctor, I know that we have all IT consumed in banking, in governance, and everything. I think this is a health IT. Health is the one area where maybe the ecosystem is such that we are not so keen to work in computer. We are very familiar with scribbling, but now things are going to change. I had to be made compulsory, like in US now is so, that President Obama has made mandatory for all the records to be in electronic versions. His own way of compensating for this extra work for the healthcare professionals. But this is going to happen. Take it from this thing. And all these people, I think 3 or 4 of us in this hall itself are members of this EMR group in ministry. How ministry is thinking seriously about that. I think, Arvind, you can add to my comments. This is very, very important for the industry. Please take it very seriously. And we want you, because the future of health IT depends on the entrepreneurs of the industry sitting here.
Thank you.
Sir,
And National Medical College Network, I think you have been spoken so many times, and the National Medical College Network is going to come. And the next question is whether private government, we have already debated in the day one. This is going to vanish very soon, because many public-private partnership initiatives are coming, actually. And I'm sure if the government is convinced that this private group is going to contribute to this national cause, I'm sure this kind of artificial barriers of, if I'm traveling in this highway, I pay toll tax, right? If somebody says that, okay, you are using it and you are going to use for the business, okay, you pay the tax for these things. Well, that is possible, I think, this kind of thing. But this is a national infrastructure. The national infrastructure will be used by one and all.
You mentioned about the government initiatives. You also talked about home care and the focus on that. And wanted to point out that there's a big opportunity there in the industry right now. The government has taken an initiative, though from a different department, to give away laptops to students, and this is going from various state governments. Close to 3 million laptops have been distributed. Each of these laptops is actually getting into a household, and the household is becoming digitally literate. And that's an opportunity right now with connectivity with the NOFN and the National Knowledge Network coming in, as and when it improves, that there is a direct chance of healthcare industry reaching out to the homes directly for home care, which was not there before. I think there's a huge opportunity in front of us. I don't think we're seeing that in the way it should be. We're looking at it more from an education standpoint and laptops being distributed, but I think if we can go back and ride on what is being given, I think it's an opportunity for us to penetrate directly into the homes over there.
You have brought a very nice point, actually. So let me tell you my experience of how this has gone to the home level. You take the help of the children who are in the home. The patient comes for treatment. I tell them that your child or your granddaughter must be using internet and using Skype. 100% I get the answer, yes, in their home now. But the other thing that I want to tell is house, you know, the only thing that is lacking in our country is advocacy. Dr. Bhatia has already told you about the government policy. Okay, in India, many things happen late. We always enjoy the benefit a little late, so be patient. But what is more concern for me, that telemedicine has not become a familiar household terms, Many of us laborers are using a mobile phone. But telemedicine has never been thought of by anybody that can happen. And we got a presentation from the audio call centers. Let me tell you, in Bhutan, they have a beautiful example of health call centers. It's going on very well. The Bhutan telehealth call centers, they have no other access except telephone in the remote hills. If you study those kind of experiments, in Nepal, they have also a call center based in the 3 universities. So the tremendous power of at least, a standard phone. There may not be a smartphone, even a standard feature phone has a lot of impact. And it has been proven well beyond doubt. Even short message services are also important for many of these vaccination alerts, drug alerts, etc. So more importantly, the advocacy. Can you not find out some ambassadors, who talk of this e-health or telemedicine in a television? I think we need the help of the society and media to make this technology familiar.
Thank you, Dr. Printing electronic medical records. And nice segue into that discussion. Last conference we had discussed elaborately about standards and the need for standards. And it was delightful to see that this time when the presenters were there, what we consider as tier 2 cities, their adoption of electronic medical records seems to be much better. And it won't be far fetched for me to say that the tier 2 cities are no longer tier 2. I think the tier 1 cities need a huge learning from them. We saw what was done in Kovai Medical Center, Kaveri centers, the Meenakshi hospitals of Madurai, which you expect a Chennai, a Hyderabad and a Delhi to do better. So that means that electronic medical records is real, it is catching up, and I think what we heard from our solution providers was it's an eternal medical record. That means it's not an IT initiative. It's an initiative of the clinicians for operational effectiveness, clinical effectiveness, and it's really not an IT project of sorts. That means that it's going to be there for long. There's going to be scales of maturity on it. And given so much of adoption, I think the focus was definitely on increasing adoption. That means training. There's no substitute to training there. And if you're looking at health information exchanges, definitely the standards. And I really would like to thank a lot of the participants who are here, who were there last year. We spoke about standards, and this year the standards are real. Thanks to a lot of your support, many of you are here today. I've heard personally from a lot of you. The standards are on the Ministry of Health website. They are real. It's not a concept. That means that it's for us to follow. Many people have asked me personally in my meetings with the government, is this going to become law? I think we have some way to go before it becomes law, but I think before we start using jargons like is it legal and all of that, I think we need to look at how we can adopt standards. That means the challenges of implementing electronic medical records will be more contained towards the benefits as opposed to implementation and interoperability challenges.
This conference, for the first time, we had a session on disaster management. Could I request Professor Russell Andrews, neurosurgeon and scientist at NASA, and who has got a lot of interest in disaster management, to please give us a quick summary of what actually transpired in that session and how he thinks is relevant to India.
Disaster management from quite different perspectives. Major General Bansal gave us an overview of the government organization for disaster response from the National Disaster Management Authority, and also went over the relationship between the public and private sectors healthcare-wise in responding to disasters. And then he talked a bit about an aspect of disaster I don't think we always think about, and that's the chemical, biological, and radiation, nuclear threats that disasters can consist of, and how the very sophisticated detection devices that are around, and how you can provide protection for stadiums for sporting events that might be targets for terrorism. Quite a different approach to disasters was taken by Dr. Rifat Latifi from University of Arizona and the International Virtual E-Hospital group, And he described more, what I guess we'd consider traditional disaster response from Arizona to Albania, different programs that he's been involved in, and very graphically presented some of the chilling effects of natural disasters and trauma. One of the statistics of 16,000 people die a day in the world from trauma. I guess he said 5 million people a year. So we've got some real challenges ahead of us to deal with those types of traumatic disasters. He's also written a book on that topic of telemedicine and disaster response. One of the other presenters, Dr. Sunita Reddy from Jawaharlal Nehru University, also has written a book on her experience with disasters, and she emphasized an aspect I think is often neglected, and that's the, what you might call the recovery or rehabilitation phase. That disasters strike and they may kill many people, but they can have a very long-lasting effect on people as well as on the environment. And so she really emphasized from her experience with the tsunami in December 2004 that struck the Nicobar and Andaman Islands, the long-lasting effects and the need for having programs in place to take care of people over time, the effects on disease and on psychological stress of being displaced for long periods after disasters. I think we tend to underestimate, and I think we see what's going on in the Middle East right now. We can really take that to heart. And then finally, I presented a model for incorporating disaster response into the healthcare systems in developing countries and trying to bring together developed and developing countries in training in neurosurgery and in related fields such as trauma and orthopedics that would be involved in disasters. So we'd have people in place who could be transported quite quickly within 24 hours to disaster sites around the world. And I think that until we can get disaster to be not a separate part from the ongoing healthcare systems in countries, but really an integral part of it, we're not going to make a real improvement in how quickly we can respond to disasters.
In health education, and I understand that there were some interesting case studies as well as some discussions around digital classrooms. So can I request Dr. Parvati Dev to share perspectives on the session?
Thank you. Yes, we did have some very interesting, not knowing which one is working here, presentations and discussions. I think we could say we covered the gamut of what is possible to talk about for tech. There was a lot of talk about physical spaces, designing for digital capture, for transmission, for essentially blowing out the walls of the classroom. So what is discussed in this room is available to the world. The classrooms around the country and the world can be linked. That interaction is possible. People elsewhere who might be in a classroom, in a village that's connected, on a phone, can all interact with the professor. So I think many different models were presented. It's very clear that this is all possible. One of the very interesting points that came out of that was when one of the participants talked about the do's and don'ts of this type of design and pleaded for doing design based on needs. Think ahead of time what you're planning to do with this space and make sure that everything you need is in there. Also think to the future and how your needs might change and make sure that you can upgrade and change as needed. I think that those are kind of cautionary ideas where people might plunge into creating something fun and interesting and then it's limiting in some way. Another part that really was very interesting was just pure talk about content of different kinds. There's lots of content being created. There's also lots of gaps in content. And one of the ways that content is being created is straight capture. You're having classes, you just capture everything. In the process, they were ending up with pretty much the entire curriculum being captured. That's one really good way to collect a lot of content. At the same time, and another point to that was, aside from what's being created in the classroom, linking into what we call e-libraries. So resources outside the classroom that one needs, including making partnerships with other universities that might have large e-libraries already and getting access to that content. I thought it was a very valuable point to make. Something that somebody brought up was How do we know about that the content is validated, accredited, that it is correct, that it's, people say, oh, I saw this on the web and it taught me how that, this surgery should be done this way and you're saying something else. I mean, that's random content you're picking up. What about having a validated, refereed source of content? There are a few models of this out in the world, and I know that a group that I work with a lot, which is the Association of American Medical Colleges, spent many years coming up with a model for how to referee this type of digital content. But it is an issue that content does need to be validated if you're going to ask your learners to use it. You need to be sure they're getting correct material. Another interesting point was, so content and validation. A fascinating point was made that we are focused on teaching the health professional, doctors, nurses, lab techs, pharmacists, dentists, whoever we want to think of. But in the end, good health is going to come for the patient looking after themselves. This is the big change we are seeing. While some patients may still want the doctor to basically command them to do whatever they should do, most people are beginning to ask questions. And the more you educate the patient, the more likely they are to comply and actually take better care of their health. And I forget who it was said, maybe it wasn't in this session, but a different one, that good learning is as good as an antibiotic. That you need both. You need the medicine, but you really need the understanding of the patient. I thought if we can provide that kind of learning, and I will go back and mention the people and kind of the areas they covered, that would just change the healthcare of the population, health situation of the population. A last item that did come up was about business models and who's paying and who's going to do what. I have to say that there was no answer to that. It ranged from we need the money and we're going to collect it from every grant source possible or funding source possible, to we are going to have, or we have a business system for delivering e-content, giving certificates, and getting revenue. So I see my time is up, but let me just say the speakers were amazing, and they included Dr. Prem Nair from Amrita Institute of Medical Sciences and Research in Kochi, with a huge range of projects they're doing. Dr. Saroj Mishra from Sanjay Gandhi PGI, Lucknow. I mean, he always has interesting things that he tells us, and he's passionate about doing it right. Mr. Sanjeev Zucchi of MedVarsity in Hyderabad, talking about how they're developing commercial models for this type of learning. And again, very interesting, very needed models that are validated. Dr. Ganapathy, who focused on patient learning and gave a beautiful example of how he had implemented it, and myself focusing on the value of experiential learning through simulation and what it can do for learners. So I think we had a fascinating session.
Thank you, Dr. Parvati. We also had see the behavioral patterns emerging between urban and rural India in terms of awareness and how it happened. So can I call upon Professor Arun Rai to come? So if you can also cover big data. Yeah.
So should I just focus on the big data part? I would not like to recap my own session, so I'll skip on that. So on the big data part, sitting back, I found data side and how it's becoming big. And I think how it's becoming big is because we are seeing an explosion in the monitoring technologies that are available, be it wearable devices that can readily communicate to other types of input streams. And what's especially striking is that you're seeing a medley of both structured and unstructured data that could both now become available to understand a given patient in a given context. The other intriguing aspect of this data is that a lot of it is now potentially real time. So the timeliness of data, the structured, unstructured facets of data, and the sensing that could occur at remote locations and then be transmitted readily, effectively, are aspects of big data. So thinking about big data outside of just traditional social media realms, but much more from a clinical standpoint, what's going on is something much more situationally relevant here. The second thing is, okay, given big data, so what? And I think it was very well captured by one of the speakers that it could be used for predictive purposes. It could certainly be used for preventive purposes. Again, that's not to the exclusion of corrective purposes, but preventive, is an option or a strong potential out there. And then there's the personalized angle, that in all of this big data, at the end of the day, there are going to be the opportunities to really understand micro behaviors and micro segments and individual aspects much more precisely. And another aspect of big data is it also provides opportunities to understand how different participants in a system could collaborate better. And that's kind of important. We think about big data, but big data also reveals opportunities or surfaces types of breakdowns in systems that may not be readily visible. And I think what big data creates is a level of transparency, potentially across machines, people, and systems that are not easily available or accessible otherwise. Of course, all of this sounds good, and I think the challenge going ahead is to figure out how innovation is driven through clinical systems and how change is affected given the potential of big data. So I'll sort of stop there because I do not want to drag this on into a full grand summary of the session, but those were my big takeaways from the session, which was, several people presented a number of intriguing and interesting examples as well to illustrate. Thank you.
Thank you, Professor Raj. May I now request, it was pretty interesting seeing his presentation on E-enabled and how to design measuring systems. And there was this wonderful session that was demoed of the Patient Connect devices. So your thoughts on that?
Professor Ganapati, Arvind, and rest of the team for organizing such a wonderful event and bringing all of us here and bringing us in one place and sharing the thoughts. So thank you, Apollo. You have been doing such a wonderful job. I want you to continue this journey. So our session was headed by Dr. Asif Dabar, a very eminent man, and was taking care of the healthcare practice in Deloitte. So thank you, sir, for chairing our session. It was really, really honorable and useful. We talked more about the changes that is happening in the healthcare market. So from moving from wired, we are going more wireless. So that is one of the biggest takeaways that we see, because we were not talking about anymore within the office. We are talking more about how we are going to carry to the rural area, urban area, and even at home. So moving from wired to wireless and enabling patients to get as close, as touch with their doctors with more information. So the idea behind it is connected care. So wherever the patient is, if they are in medical tourism or anywhere, if they want to talk to the doctor, do they have the ability and can we provide the ability to talk to the doctor? So that is the biggest takeaway. So we spoke more about telemedicine, we spoke more about connected devices, and we also spoke about how we can bridge the gap between the patients and the doctors. Thank you very much.
Can I request Dr. E-health and adoption around the world as we see electronic records?
Thank you, Arvind. This was definitely a very intriguing session that truly exemplified how e-health has been transforming healthcare across the globe. The 5 speakers in this session came from various parts of the globe, and they touched on various aspects of e-health. Well, how did e-health come into play to begin with? Well, e-health was a response of 21st century healthcare to a lot of challenges that was faced by healthcare right around that time. One of them was the spiraling cost of healthcare, which was faced mostly by the countries in the Western Hemisphere. The graying of the globe. I don't know if you've heard this term, but the graying of the globe truly basically reflects to the fact that a large percentage of the population around the globe has been graying at a faster pace than even we can keep up with it. And India is one of the fortunate countries where the graying of the globe hasn't impacted us as much. So there is a large, healthy population in India that can support the older generation. But the rest of the world, especially the Western Hemisphere, Japan and North America, has been faced with this problem. Well, why is that a problem? Because a lot of the people in that population segment also are suffering from multiple chronic diseases, which are then again driving the healthcare costs. E-health was basically came in as a knight in the shining armor and thought and was supposed to be an answer to a lot of these questions that could alleviate healthcare of all of its pains. Now, it's really not a silver bullet, as most of the speakers actually touched on, but it does have the potential to be one. And Lord Nigel Crisp summed it up very well by saying that the next wave of e-health will have to focus on empowering the patients and redesigning the job and the tasks of the physicians so they don't have a cognitive overload on more things that they have to do, coming up with more analytics that they have to see, assessing more and more of the data that is coming in from all of these pervasive devices, from EMRs and from everything else around them. So a lot of the focus will have to be on data analytics and how to make their job a little bit easier. That is not to say that the physicians are ever going to go away. We'll always need them. We'll have to sort of kind of find a way to utilize e-health to make the job a little bit easier. So technology is, of course, going to transform healthcare in a big way, and I think all of us do agree to that. So thank you so much, Dr. Ganpati and Arvind, for giving me an opportunity.
Thank you, Doctor. May I now request...
Issues are there. I will not talk what happened, but I will talk what we have to do in future. What are our problems? I said earlier also, software is not a problem at all. Problem is with hardware. Hardware is related to medical equipment. What we need is to get the parameters of patient without bleeding. We want devices which we can put on the patient, get the parameters wirelessly on our mobile, transmit to the doctor or store somewhere. So working in that area is very, very important. People who are concerned with it should concentrate on that. There is a market also, a huge market available. Once it is done, definitely software people will interface it immediately. That is what. You have, say, diabetes patient regularly measuring their parameters regularly. This is a basic requirement, but without clicking. It can be done. There's nothing, I will say, which cannot be done. This is my perception that if I understand the problem, mostly I spend around 65 to 70% of my time on understanding the problem. Once I have understood the problem, 35% of my time I take to resolve it. There are hindrances. You may come for version 1, version 2 also. So at this moment, the requirement is, I think, bandwidth, other problems are being solved step by step, and we have come a long way. Softwares are available they can do anything. But how to get the parameter of patient, there is a gap. I think we have talked a lot, we have given a vision, people have given the vision, people have discussed it out. My sense out of it is this one point. Second point, which I would like to request Dr. Ganpati, India needs dollar. And medical is one field where we can bring dollars. we have missed the topic of medical tourism in this conference. We should work, particularly hospitals, should work in promoting medical tourism in a good way. This is also one, I will say, perspective in which we have to think of. I have developed one software on medical tourism which takes care of the patient from inquiry of the patient till he settles down back at his place. Total tour has own software. He can be guided where to catch, who will be the person, who will be the doctor, what has been done, what are the parameters, all records will be there. That is there. So these are the two things which comes to my mind, which was the thank you.
Thank you. Before I ask Mr. Rajamani to give the final remarks, is there anybody from the audience who would like to say something, including our overseas visitors? This includes comments on whether you like this conference to continue. If so, how do we make it better? What exactly should we do? Any comments are most welcome from the audience. Anybody in the audience who has not spoken, I think the very fact that all of you are still here shows that you are tremendously interested. Please do give us your frank opinion, particularly those who have not spoken before. Yes, please. The others can also come straight here so that we can save some time. Please do come and voice your views, whatever it is.
Right now, the attention levels have come down. But then, sitting over the last 2 days, one thing that has come out very clearly is that after being exposed to what is actually happening in the US, we still have a lot to go. But what's more important is the intent is there. What I did not see being actually addressed by most of the presenters was the rigor of implementation, which seems to be missing still. Telehealth by Apollo is something I think which I saw the best rigor as far as implementation was concerned, and as far as stalls were concerned. I also spent some time on the stalls. But I would like to also see that there is more focus on talking about the supply side issues which are actually affecting this entire sector in a very big manner. We don't have adequate doctors as far as India is concerned. And I think the government, as well as most of the authorities, including the MCI, is woefully failing in its duty in being able to create that supply of trained manpower at different levels to be able to take care of the various needs of this nation as well as the people. Technology alone will not help. You heard what Vinod said yesterday. People, it's the final decision maker, and the arbiter is the person. And if the doctor is not available, you might have the fanciest of technologies, but the results will not show. I think that's what I would like to leave the entire session with. Thank you.
Thank you, sir.
I'm from Savia. This is a company I started after working at AMD and ST Microelectronics as a chip designer. It's very nice to see more people talking about devices in this conference this year compared to the last year. Just I want to address the comment made by Dr. Bhatia. The devices are now very easy to make. These are just like now as easy to make as cellular phones and televisions and GPS systems. This is because the semiconductor companies, especially the ST Microelectronics, whom we work very closely with, they have complete reference designs and manufacturing partners who are available. I am very happy to see American Megatrends doing their BP monitor, but we would be very happy to see many more people in India trying to be OEM startups, and we are there to support with the complete design knowledge and manufacturing connections. So please contact me, and also with organizations like CDAC and Apollo. We'll be very happy through them to reach to the entrepreneurs who want to make the devices in India. Let's not miss this opportunity. We missed many opportunities. We missed televisions. We missed cellular phones. Many, many things we have to import, laptops, iPads. So let's not miss medical devices. Thank you.
Conference, and I want to thank Professor Ganapathy for asking me to participate. There's kind of this is information technology. There's another side of information technology in healthcare that I think is complementary, and it might be interesting to get it involved in well, and that's the whole area of genomics and personalized diagnostic techniques. We there's a wedding there that I think could take place in the future in this conference. It might be something to keep in mind.
It's a good suggestion.
And very, very good evening. I am Dr. Saxena. I am Director of Medical in Border Security Force. In fact, I was at Hyderabad in CRPF as Medical Superintendent. And I just very recently assumed the charge as Director of Medical, BSF, Border Security Force. As you people know, the BSF, my Jawans are deployed in very, very far-flung areas, very remote areas of the country. And when I came to know about this conference, that's why I have come from Delhi all the way. And it is a thrilling and wonderful experience for me. And I've talked to Dr. Bhatia, and I think there's a huge opportunity for me to implement this telemedicine concept in Border Security Force. Thanks a lot, organizers. And I think we must have regular this kind of conferences. Thank you. Thank you very much.
Arun, your thoughts now?
It's just 2013's been too heavy on me, I think. I'll start with that because I was in Russia a month ago, and I attended exactly a similar format of a conference, which is called Healthcare and Information Technology in Kazan, and it's a national level conference there. And then I got an invitation when I was I was traveling personally in Delhi. I'm just trying to relate how it looks to me from my perspective. I'm not a healthcare and IT guy. I'm not that geek. But I think about from a perspective of myself how I'm going to use my healthcare need down the line as a user, as a doctor. And what I found out is there's a lot of answers that you guys try to answer it from here, which I didn't get in some other part of the world. Whereas I studied there. I studied in Russia and then I came back here. I practiced in Nepal. I do something new for the subcontinent, even for the people who are here can actually relate to me, or because I relate to the healthcare need of myself in India a lot. My family does. So growing in this part and then having such a nice thing, I really feel nice, and it's a really nice thing that you guys have done, and you should do it every year. And I'll try to come down with new projects. Thank you.
Short. I have the privilege of representing the industry as I thank Apollo Group for putting together such a wonderful event. I think we've been proud to be associated with that, as well as the sponsors who have supported that. I'd like to thank them for that too. It's very clear, looking at the sessions and the feedback and the summary that's come in, that the 4 game-changing technologies, which is cloud, big data, mobility, and social, I mean, they're here to stay, and they are the ones that are going to transform the entire healthcare industry. It's also heartening to see from the sessions that the government has also been backing it with great policies and when you have great policies and great technology, that's bound to have an impact on how the industry will work. So I have no doubt that this represents a huge opportunity for us all, and the future is only going to be looking even more better there. So thank you again, Dr. Ganpati and Arvind, for putting this together and for inviting us over. It's been a privilege to be here. Thank you.
Truly delightful. We've enjoyed this. Before we close, we definitely want to acknowledge the great back office support that we've got. Trust me, none of this would have been possible with a lot of us truly driving you crazy. Thank you, and we will continue to drive you crazy because this conference is happening again next year.
So thank you everybody, and we also like to thank our volunteers, all our managers, all the people who put this together. So thank you once again. We do hope we'll meet again next year. Thank you.